so that the humanity of how you approach a family or a patient is there awake is much more important and doubly important, I would say, because of the scenario that you're in. And
Yes.
we talk about neurologists having longitudinal relationships at the MS clinic, or oncologists having lifelong relationships. As intensivists, we don't have clinic and we don't have a longitudinal relationship. But because these families and these patients are in such grave, acute situations, they are at their most vulnerable, they are at their most scared. And that's where treating them as you would your brother or your sister or your mother or your father, it becomes that much more important. And believe it or not, if you can treat them humanly and create a connection with them, that makes your job that much more fulfilling, even if you can't save the patient. I mean, I can't tell you guys how many times.
Welcome to the Critical Chats podcast,
Or as I'd like to call it, Crit Chat,
where we talk about the new and exciting developments in the critical care world and get to know the providers behind the medicine.
I am Sheila Billica, PA.
And I'm Katie Shakura, PA. We're your hosts, and we're with our producer, Sneha.
I'm also a PA.
3 PAs on a pod.
Today we are joined by Dr. Raphael Carandang, a neurocritical care physician who cares for patients facing life-altering neurologic emergencies, from severe strokes to traumatic brain injuries, where minutes matter and decisions can define outcomes.
In this episode, we break down what really happens after a traumatic brain injury, or a TBI, how critical care teams monitor and protect the brain in real time, and why individualized, data-driven treatment is reshaping outcomes. We're also going to talk about the BOOST protocol, what it is, how it guides brain oxygen monitoring, and how it's changing the ways clinicians approach secondary brain injury.
So whether you're a clinician or a TBI patient like myself, a student, or simply curious about how medicine pushes the limits to save brain function, this conversation offers an inside look at the science, strategy, and split-second judgment behind neurocritical care. Welcome, Dr. Carandang, to the Critical Chats podcast.
Thanks for having me.
Yeah, we're really excited for this episode. I actually just came from working in the neuro ICU, so I'm amped up right now. But for our listeners, tell us a little bit about
Don't have a stroke, please.
I won't. Maybe. Tell us about yourself. So how did you start in medicine? Where did you go to school? How'd you get here?
So I was born in the Philippines, and I did my undergraduate and graduate training there and went to medical school at the University of the East, Ramon Magsaysay Memorial Medical Center in the Philippines. After that, I did an internal medicine residency in the Philippines. And then after that, I was able to have an opportunity to come to the United States to do neurology residency. So I had to do another internship in New York, and then I did neurology residency at the Boston University, Boston Medical Center program. And because I couldn't stop training, I ended up doing a stroke fellowship at the Cleveland Clinic for a year before coming back to the Harvard system at Mass General and Brigham for neurocritical care.
Wow. That's very impressive. So you just got interested in neuro and just went down that path?
So no pun intended, he has a big brain.
Big brain.
So actually, my father's a neurologist, full disclosure. My mother's a clinical psychologist. And at that school in the Philippines, the University of the East, Ramon Magsaysay Medical Center, the neurology faculty had trained all over the United States, including at MGH, where our dean came from. My father trained at UC Davis. Some people came from Case Western or trained in Japan. And they all came home and became the most esteemed faculty in that school. So everybody that comes from that school was inspired to do neurology at some point in their training.
That's amazing. Do you have a brother who's a neurosurgeon too?
I do not. I'm the only doctor amongst my siblings.
Oh, that's amazing. What keeps you motivated after years of practicing and researching in such a demanding specialty? How do you emotionally process the intensity, high mortality that comes with this field?
So it is still the most fascinating field for me. We're dealing with the organ system that makes you who you are, that impacts your personality, your quality of life, the things you can do and cannot do, your appreciation for the environment, more than any other organ system, with apologies to all of the other organ system specialists.
The nephrologists are all crying in the corner.
I mean, cardiology is pretty important.
But it is a pump. And at the end of the day, it serves to perfuse the brain, which makes you what you are. So it is fascinating. It is impactful. It is complicated. It's still a frontier. And it's ever challenging because of the complexities when you put them in the neurocritical care environment as well.
Yeah, I think my favorite part about working in the neuro ICU is it's such a teaching environment. I think a lot of people would agree that you're an excellent educator and very up to date on all the, recent guidelines and research that's happening. And I don't know, it's just an exciting time. Like the brain, we don't know a lot about it, but we know a lot, but we don't know, but we do know.
I know. So I was in a very bad car accident and I had TBI, basically. I couldn't read and I whatever. But how do you define TBI? What the types, grade, severity, all that?
So traumatic brain injury, or TBI, is unfortunately still being classified by the Glasgow Coma Scale, which was created by two neurosurgeons for research in the 1960s. And it's classified based on eye-opening verbal output and motor responses on a scale from 0 to 15, with mild, moderate, and severe, depending on the number that you score. It's an extremely crude measurement of severity, but unfortunately has overtaken or gone beyond the research sphere and is now being used as a way to classify people clinically. The problem is it does not account for the various pathologies that cause the TBI. So a subdural hematoma, an epidural hematoma, a contusion hematoma, and an accidental injury. They're all different pathologically, and their processes and their courses are different. So the big problem with TBI over the years, which is why it hasn't been a very exciting topic that neurologists and neurosurgeons have done research in the past, is that everybody has relied on this very primitive, crude rating scale for severity. And the heterogeneity of pathology has not been fully, parceled out or researched the way that other disease processes can.
But that being said, we do the severity based on the GCS, right?
That's right.
So what are the different severities?
So 13 to 15 is mild TBI. If you're 15, then you should be like all of us in this room, completely neurologically intact, able to follow commands, opening eyes spontaneously, and speaking normally. When you get down to 14, 13, your verbal output can get confused. Below 13, that becomes a moderate traumatic brain injury, and then less than 8 is a severe traumatic brain injury. But as you can imagine, there's multiple confounders to the Glasgow Coma Scale. If you're intubated, what is your verbal output? If you're on a sedative, will you open your eyes? So it is very crude, and it is unfortunately what we use, but everyone knows that these are limitations.
I feel like we see a lot of severe and moderate TBIs in the neuro ICU. Tell us about sort of your management or just how you approach a severe TBI patient.
Yeah, so the main point of the neurocritical care unit is to individualize assessment of what that TBI is. We do use the Glasgow Coma Score, but that is not an adequate assessment of what that person's neurological function is. It doesn't replace a thoughtful bedside neurological examination. It doesn't account for cranial nerves, for example, or breathing patterns. And you have to account for intoxication or medications. So it's actually a pretty complicated assessment. But the number one thing that we need to assess in every patient that comes into the unit, whether it's a TBI or not, is what is their brain function? What is the valid, unconfounded neurological function of that brain? And to this day, there are not any surrogates for that. As much as people like to focus on imaging and CT scan findings and look at these dramatic, bleeds in the head and injuries and strokes, none of those pictures tell you what a brain is actually doing.
That's
They always
true.
say correlate clinically.
That's true, because I remember patients coming in, you look at the bleed and you're like, oh my God, this person is probably needs an EVD. And they're like, hi, how are you? I know where I am. I know what I'm doing. I'm like, what? How are you? And then sometimes you see this tiny bleed and then
It's like out of proportion to their tiny little bleed. And
that's
you're like,
right.
what else is going on?
Yes. So,
And sometimes you need further imaging,
Yes.
an MRI.
do you know what patients scare me? Patients that scare me are the one with the elevated ICPs and
Yeah. So tell us about elevated intracranial pressure and why that poses a risk for patients.
So we all think that the end substrate for brain injury is still ischemia, or lack of perfusion, lack of oxygen, lack of glucose in an organ that's very, very sensitive to glucose as its main energy substrate. So anything that will compromise that will ultimately be the kind of insult that creates permanent damage in the brain. So the reason that we are worried about different pathologies that cause increased intracranial pressure is because we think that its effect on cerebral perfusion is detrimental. The higher the pressure, the lower or the more difficult it is to perfuse the brain. So it's not actually the ICP in and of itself, but it's more cerebral perfusion and the effects of that on the brain causing injury that's more important. And some people mistake the ICP as an end-all, be-all data point. It is a surrogate for cerebral perfusion and brain injury.
So yeah, sometimes we do put intracranial pressure monitors in our patients, but that might not be everything. Interesting. And, I heard about this Monroe Kelly doctrine. Can you tell us about this?
Obsessed with that thing.
It's important.
So it's an old doctrine from the 1800s created by Monroe and Kelly, where you basically have Boyle's law of physics in a box, where there's a limited amount of space in the skull. Yes. And any increase in any component of that, whether it's the blood or the brain swelling, can cause an increase in pressure and a subsequent compromise of perfusion because of that. And they're directly proportional. So any slight increase in volume can cause a dramatic increase in pressure. And if that can cause a cerebral hypoperfusion, that can be damaging to the brain. And that's why we do put these monitors in, and it is a guideline of the Brain Trauma Foundation that in severe traumatic brain injury, in the proper setting, most patients should have a monitor because their exams are confounded by concussion or sedation and very difficult to assess. And that's when we have to rely on surrogates like a monitor.
So where do these monitors go in the brain?
So more often than not, the neurosurgeons will put them through a burr hole in the right frontal lobe because that's the cortex that is least eloquent and won't cause permanent functional damage as far as we can tell. So that's normally where they put it. They can both put a parenchymal bolt that just sits on the surface of the brain, or they can put an external ventricular drain that goes into the ventricle. The advantage of the latter is you can drain fluid out and, by the Monroe-Kelly doctrine, decrease the volume of contents in the skull and decrease pressure and relieve some of that intracranial crisis.
So both diagnostic and therapeutic, whereas the bolt is simply diagnostic. So what happens if the ICP gets too high with the brain? Besides the hypoperfusion, I feel like something's got to give.
So there's multiple things that can happen. Hypoperfusion in and of itself is probably the end substrate, but clinically what you can see, depending on what you're dealing with, if it's an epidural or subdural or a focal mass lesion, increased pressure can be the sign that there's herniation that's impending, that shifts are starting to happen, which can compromise or crush the brainstem and cause compromise of pupillary reflexes. And as you all know, the seat of wakefulness or the reticular activating system resides in the midbrain and upper pons, and the thalami are also part of the brain which lights up or is responsible for how we can all be awake outside of diffuse brain processes. So any kind of herniation that causes an injury to those structures in the midbrain, the pons, or the thalamus bilaterally can cause you to be put in an irreversible coma.
This is serious stuff, but I keep thinking about Hollywood, how they always go, if someone has a head injury, you can't sleep, wake up, you can't. That's what I keep thinking about. Is that really true?
I think about like Looney Tunes when their brains just explode.
So there is a basis for that, but that's mostly based on an epidural hematoma, where you get a sudden hit and then you get concussed and you're out of it, and you're lucid for a while the epidural grows from an arterial bleed. And then hours later, that can cause enough pressure to cause herniation, and you may not wake up. So that period is critical, and that's probably where the cultural, phenomenon of not letting a TBI patient sleep comes from.
So when a patient with a severe TBI arrives in the ICU, what are the 3 priorities running through your mind?
So just like anything else, it is the basics of airway, breathing, and circulation, believe it or not, because at the end of the day, when your brain is compromised, you're not protecting your airway, you may not be breathing well, because the brain controls everything, including heart rate and blood pressure and responses, autonomic responses.
The more important organ, if you will.
All of those things come into play, and you can't have severe hypotension or severe hypoxemia because the brain is exquisitely sensitive to these insults. And in the setting of brain edema or traumatic brain injury, those results or those effects can be amplified and make things much worse. So it is making sure that they're protecting their airway, their oxygenation is okay, their perfusion is all right. And these are critical questions in terms of what is a mean arterial pressure or cerebral perfusion pressure that you need to pursue.
Yeah.
And how can we decrease intracranial pressure? Medically, surgically, etc.
So we do have medication that works. There's osmotherapy with an old drug called mannitol, which is an osmotic diuretic, which uses an osmotic gradient to pull water out of cells and decrease the volume of the brain. There's a hypertonic saline, and the kind that we use in Lakeside 2 in the neuro unit is highly concentrated, 23.4%, which is exceedingly superphysiological, but that also serves to pull fluid out and shrink the brain and cause decreases in intracranial pressure and reverse herniation. And we know that both of those things work, but there's a limit to how well they can work depending on how big the lesion in the brain is and how much space you have left in the brain.
And your serum sodium and your osm gap. So, yeah. And so then alternatively, you could pursue surgery.
In proper setting, yeah.
Yeah.
Just give me a headache.
Yes, very much so.
How did we get to Boost?
Yeah, so the Boost trial. So I know that we're doing a lot of Boost trial patients here at UMass. Tell us first off where Boost even came from.
So before that, UMass and our group has done a lot of research in traumatic brain injury precisely to address two major problems with traumatic brain injury in terms of research and clinical care. One is this coarse grading scale, which doesn't suffice, the classical coma scale, right? Characterizing the different pathologies is an important step in understanding and treating patients with traumatic brain injury. The second is this idea that the trauma that you come in with and the severity of that is going to be the result or, the outcome of what you get. These are two fallacies, and these are true problems because you can get better from a traumatic brain injury and you can look horrible at the start of your admission, depending on what's going on. And our group at UMass has worked very hard to produce research to dissuade people from falling into those two traps. We've done papers to characterize diffuse axonal injury, for example, which used to be a severe, devastating diagnosis, but now has become a radiological one where they just look at microhemorrhages on CT and MRI. And we've seen that patients with diffuse axonal injury, or more properly, probably should be called traumatic axonal injury because it's not diffuse, actually do okay. And the other is we've published papers on the self-fulfilling prophecy in clinical nihilism and traumatic brain injury. And those are two very important components of that, so that we can get to the natural histories and give patients a chance to get better by better understanding both pathology and not being too nihilistic about it. But in terms of the management, that's where Boost comes in. What are the various tools that we've used or that we can use to improve or prevent secondary injury that you were mentioning and further hypoperfusion? And intracranial pressure is one that's well known with the ICP monitors and the EVDs, but studies have been done looking at regional oxygen in the brain during times of crisis. And the reason that Boost exists is because in preliminary studies, they found that people that have normal intracranial pressure and have periods of hypoxemia regionally, not diffusely, because you have the pulse ox for systemic oxygenation, right? But in various regions. And the question is, are those regional episodes of hypoxemia deleterious to brain function and recovery? So they did a preliminary phase 2 study where they looked at putting in both regional oxygen monitor with an ICP monitor. And they noticed that there were not always congruous. There were times when the patient had ICP elevations, but no hypoxemia. And there are times when the patient had hypoxemia without ICP elevations. And there are times when they had both. And in preliminary phase 2 study of Boost, with these monitors in place, they first noted that it was safe because it was a phase 2 trial. There were not more complications in the group that had an extra regional oxygen monitor. But also there was a trend towards better outcomes in those that got both monitors versus those that only got the ICP monitor. And that's where Boost comes. We are now in the phase 3 of this multi-center, multinational trial, trying to recruit up to 800 to 900 patients to see if clinical outcomes are better if we use an oxygen monitor to guide management rather than just rely on ICP.
It's awesome. That's a large population of patients, so you get good data.
Absolutely. And what you like about the trial is it's a very pragmatic clinical trial. It's driven by clinicians at the bedside deciding when a monitor is needed, managing patients the way that we normally would. There are certain tiers and protocols on how we manage an ICP elevation, an oxygen decrease, or both. But they aren't very far from what we normally do to treat these patients anyway. And there's a rationale for each of those interventions pathophysiologically. It's not just cranking up PFiO2 when the oxygen drops.
Yeah, really thinking about the pathophysiology. Yeah.
That's right.
Yeah, it's pretty cool. We have like this binder in the neuro ICU that, when we have our boost patients, we can look at, because there's a lot. There's a lot of information. You kind of have to know what to do.
Yes.
It's a bit scary for sure.
Very scary for me.
But I do think that this is awesome. And so what's the sort of like inclusion criteria for some of our patients?
Yeah, so for boost, it has to be a severe traumatic brain injury or a Glasgow Coma score of 8 or less. They have to be viable patients, so patients that have fixed and dilated pupils are excluded because you want to follow up their outcomes at certain time frames. If a patient, if someone has severe pre-existing hypoxemia, then they're excluded because that might affect the oxygen monitoring. Pre-existing neurological or functional disability, because you want to get a homogeneous outcome for your assessments. Right. The trick is that the monitor has to be placed within 6 hours of arrival to the hospital, which can be challenging to do logistically if a patient is stuck in the ER, can't get up to Lakeside where the nurses are trained. But those are the main criteria, and I believe it's actually age 14 and above and not 18 and above for the first trial.
Okay. So when ICP and brain oxygen numbers conflict, how do you prioritize or reconcile?
So there's different scenarios in the boost trial. One where there's just an ICP elevation, you do the normal osmotherapy or management or augmenting perfusion to see if they'll respond. There's a second scenario where it's just an oxygen problem, and depending on what the problem is, you could choose to increase perfusion, look for causes of increased oxygen consumption like a seizure, even transfuse blood to improve oxygen delivery in certain instances. And in the combined scenarios where both crises are happening, you have all of these things at your disposal. But there's a whole list of interventions that you can do, from as simple as raising the head of the bed and making sure the neck isn't compressed, to increase outflow, and to giving a sedative, to giving an analgesic, to sometimes increasing the FiO2, doing pulmonary toilet, or improving the perfusion to see if those things improve scenarios.
Excellent. That's very cool. I can't wait to hear, what comes of this, because boost is very ubiquitous in the United States. Like there's like tons and tons of institutions that are enrolled in this trial.
The multi-center, there's many, many centers across the country, and I've been up in Canada as well. They're involved in this trial.
That's very cool. So I was reading about TBI and sort of the research that's been going on. I was reading about, temperature probes and microdialysis with like a lactate pyruvate ratio. Are these things that you feel are going to be the future of TBI management as well as boost? Like, where do you see everything going?
Yeah, there's a lot of research going on right now, but like I told you, this is way behind research in other neurological diseases for the various reasons we talked about. So even now in 2026, there's a consortium working to standardize definitions and terminology in traumatic brain injury, which, if you think about it, is something we could have done maybe 20 years ago. They're looking at biomarkers both in the blood, including GFAP or ubiquitin-1 or neuron-specific amylase, and tracking the various timeframes that those biomarkers will increase in somebody with traumatic brain injury. There's imaging biomarkers. There's electrophysiological biomarkers. So there's a lot of research going on, including microdialysis, which is actually pretty old. The problem is many of these things have not come to clinical practice yet because they're not easily accessible. Yeah. The microdialysis catheter is very complicated and not
expensive.
It's not available in many centers, including UMass. We don't do microdialysis here. The higher tier electrophysiological studies are also not readily available in most trauma centers. And we don't routinely use blood markers yet to say that one patient is going to do poorly or not. And as the research develops, these hopefully will become something like the troponin that will be predictive. But the problem is the brain is inherently
complicated and difficult to assess. And because it has so many functions that can't be captured by a surrogate marker, whether that's even functional neuroimaging, which is now the big deal in terms of cognitive motor dissociation in comatose patients, isn't practical, isn't available. And in my view, from a clinician that takes care of patients, none of these things yet contribute significantly or more than what the patient's neurological examination tells us, which is still the most important data point. And people tend to forget that when they get lost in all the sexy research that's going on. There is still nothing that replaces a neurological functional assessment that is unconfounded to tell you what a patient can or cannot do and what their trajectory for improvement is.
Said from a true neurologist.
Yes. Yes. So this is very. So are we at boost 3 or are we still doing boost 2?
We're at boost 3 now. This is
Boost 3.
multi-center
Okay.
study
All right.
to look at clinical outcomes.
Okay. So boost 3.
So we are at the future right
Okay.
here.
Yeah. Do you see a boost 4?
Hopefully not. So if boost 3 study does show that the outcomes are improved by a significant statistical margin in the groups that have oxygen monitoring, that should hopefully become more of the standard of care for these types of patients and hopefully will lead to better outcomes.
I was going to ask you what makes it so difficult and challenging, but then I think you answered it throughout the entire podcast. So now I'm going to use this podcast when we have a TBI patient. We can watch, okay, we're doing this. Oh, yeah, this is what we're doing that for. I'm going to use this to write my notes, I'm sure. Did we mess you up? No? Okay, we did great. Okay, awesome. I do have questions about
Dr. Carandang in general?
Yes.
Yeah, so Dr. Carandang, tell us about what you do on the side, some hobbies. How do you cope?
Okay, wait. Let me start by sharing my story. When I started working at UMass doing neurocritical care, I used to play soccer. Okay, I stopped playing soccer. I used to sing in a choir. Okay, I have done it up until about a year ago, and I started drinking instead because 2 lakeside is very disconcerting for me. So, what do you do?
So there's a couple of things that carry you through the complexity, the acuity of the Lakeside unit, where patients are very, very sick, as you guys know. It's very complicated.
Yes.
But, a couple of the things that keeps us motivated, number one, is that it's never boring. It is always a challenge cognitively to find the best management. And this is where you have to pull on all of your resources and expertise, know the evidence, know the underlying pathophysiology, know the individual patient and what they would want in certain instances, and try to bring all of that together. That is a complex analysis and a very stimulating cognitive exercise, which I'm not sure other practices afford you.
Right.
So that keeps you stimulated from a purely cognitive standpoint. But you're right, it can be emotionally draining to see patients and to lose patients and to see families in duress. But believe it or not, one of the aspects of neurocritical care, which is undervalued and difficult to teach, is that, there's this misconception that intensivists like to work in the ICU because they want all their patients to be sedated and intubated, and they don't like human interactions. But I would argue that the neurocritical care environment is that much heightened, that much more critical, and that much more profound in terms of the kind of outcomes you can have that will affect you and your family and your loved ones. So that the humanity of how you approach a family or a patient as they're awake is much more important, and doubly important, I would say, because of the scenario that you're in. And we talk about neurologists having longitudinal relationships at the MS clinic, or oncologists having lifelong relationships.
As intensivists, we don't have clinic and we don't have a longitudinal relationship. But because these families and these patients are in such grave, acute situations, they are at their most vulnerable, they are at their most scared. And that's where treating them as you would your brother or your sister or your mother or your father, it becomes that much more important. And believe it or not, if you can treat them humanly and create a connection with them, that makes your job that much more fulfilling, even if you can't save the patient. I mean, I can't tell you guys how many times I've presided over a family meeting to tell a family that their loved one is brain dead or they're not going to make it. And I do feel that their thank yous after those meetings are some of the most sincere thank yous that you'll ever get in your practice. And that carries you forward. So those two things, I think, fulfill us. Having that connection with the family, the patient if they're awake, the staff, the team, that we're all working together for these patients. I think that carries the day, and that makes it fulfilling and takes care of the emotional turmoil that you might have. Because we're all in this together, right? We're all working for the same goal, and we all understand what people are going through.
Yeah, definitely rely on my colleagues to decompress and talk about everything. Right. And, we share our patients, and it's really hard.
It's hard. It's hard for me a lot.
Yeah.
I hear that you sing.
He's trying to avoid it.
Are you going to sing with me? When things are bad, you're gonna sing with me when things are bad.
Yeah. So some of the things that I do when I'm not in the unit are I'm part of a liturgical choir that sings for the Filipino community that has regular masses in Boston College with a Filipino Jesuit priest and a community of professionals that live in the Boston area with their families. And it's like working in a team, right? If you sing, as you know, choral singing has a special thing about it where you have to listen to each other, you have to blend with each other. You kind of create something that you can't create by yourself by singing as a group. And if you sing well, then you create something beautiful and inspiring that can take people, out of their current states of, distress or inspire them. So I think that's incredibly fulfilling too.
Yeah.
I agree.
That was like me in 7th grade when I derailed my chorus, singing off key, Edelweiss, it all works out in the end. Oh, that's awesome. Well, glad that you have an outlet because I feel like I'm constantly, when you're working so much and you get tired, sometimes you just come home and just lay on the couch and you're like, what even just happened?
Yeah, I know.
So it's good to have outlets, and burnout is very real in the ICU, especially in the neuro ICU.
Have you ever felt it, burnout?
Probably. I mean, self-maintenance is really important too, Katie. Like if you need to sleep, you need to sleep, right? If you need to rest, take a break. Outside of singing with a choir, we have a wonderful Filipino community in the Boston area. That's a bunch of professionals. Many of them are doctors too. We can bounce ideas or stressors off of each other. My wife is a physician too. She's a pediatrician. She's not currently practicing, but she understands, what I go through. So having people to decompress to is a big deal as well. I like eating a lot. I was going to say a drink can help, but I don't really drink that much. But enjoying your life and your time with your loved ones and just treasuring that time, particularly because you know that it's fragile and it could be taken away.
Yeah.
Any point.
I mean, that was like your car accident. Like you just see your life flash before your eyes.
That's right.
I feel like working in the neuro ICU makes me appreciate life so much more. And also I get very nervous when people aren't wearing helmets. I literally just saw a mom and her 2 kids and they were rollerblading around a park without helmets. And I was like cringing the whole time and, having to chat with some people about their choices. But, everybody do you. But it does make every moment so much more special when you have such meaning in your work.
Right. So I hear so the 3 things we usually ask people about what they do when they're out of here to deal with the burnout is I hear you eat a lot. Mm-hmm. You share your love of singing with your community. You decompress with your family and your friends. So what else do you do? Was that 3? Was that 3 things?
I think that's 3, but we can always add a 4th.
Okay, yeah.
Well, I think regular exercise is important. Okay. And sleeping. I really sleep well.
So you are on the labels protocol.
I love the label study, as you know.
We refer back to episode 2
I think everybody needs to get a good night's sleep. I think that's healthier for everybody.
Yes, I agree.
Well, thank you so much. What would you say your anthem song or quote would be?
Yes.
So I don't know if you're familiar with this song. It's from the 80s, but Peter Gabriel, who's a British musician, composed a song called In Your Eyes, which is a wonderful musical piece because it blends African percussions and synthesizers, and it's got a nice rhythm to it. And there's this vocalist from Dakar, Youssou N'Dour, who sings on that with a beautiful voice. But the message of the song is precisely, it's about connection. It's about in your eyes. If you listen to the lyrics of the song, the person is lost sometimes, but they find themselves in connection with individuals, with people. In your eyes is a way to connect. And many view it, and it's been used as a romantic song because it's the song that John Cusack was holding the boombox on for Say Anything. But I think it can be interpreted in a much more profound way when we talk about connectivity, when we talk about how we connect with our patients, how we connect with each other, and how that gives meaning to us. I mean, there's a line there that, a 1,000 churches, it becomes almost a religious experience and gives meaning to your life if we can connect with each other. So I think it's a much more profound message than just the romantic message it's been linked to. And it's a really good piece of music, too, if you listen to it.
That reminds me of the GCS, the Glasgow Common Scale.
I was just thinking about.
When you've heard the nurses say, there's nothing going on. The patient does not, we talk about
Lights
how the patient does not regard,
home.
They don't even look at you. And you can see it when they open their eyes, whether they're connecting with you or not. It's true. Mm-hmm. It's very true.
Well, Dr. Carandang, thank you so much. This was an awesome episode. We are thrilled that you were able to join us today.
Thanks for having me. This is a great podcast. Keep up the good work, guys.
Oh, thank you.
Thank you so much for coming. Really, we truly, truly appreciate it. And we appreciate the fact that you treat others
with such dignity.
And that you teach us as well. So I love that.
Thank you. And thank you for taking great care of our patients. You guys know that you guys are the mid-level group across the country that I think has the most skill, the most experience, and gives the best care to our patients, including the Lakeside nurses.
Yes, definitely. Oh my God, the Lakeside nurses.
Shout out to them.
Yeah.
They're awesome. All right.
Thank you.
Thank you.
Thank you for joining us on another episode of the Crit Chat podcast.
It's critical chat, Shayla.
Remember, you can watch the podcast video on YouTube or listen to us on Spotify, Apple Music, CastBox, or Amazon Music.